York, and today I'm going to be talking about mitigating femoral fractures. Thanks for inviting me to this AHF meeting. It's really great to see a lot of my mentors here and good friends. And I'll give you my take on this challenging topic and hopefully wake you up before the Shark Tank. All right, so these are my disclosures. They are relevant because I do consult for Stryker, and I'll be talking about some of their implants. So we all know that periprosthetic fractures are a major problem still in hip replacement, and while the incidence is low, if you look at the AJRR data, it's the number 2 reason for early revision. And if you do enough surgery, it's going to happen to you. It's just a matter of doing surgery. It's going to happen. And as anterior approach surgeons, we're always told by our posterior approach colleagues that we're putting our patients at risk, right? I can guarantee you that our collective experience in here probably beg to differ. These are the kinds of fractures you see, right? So calcar fractures, trochanteric extensions, femoral perforations, and this weird one on the bottom right, which happened to be in Charlie Lowry's talk as well. I actually found this on LinkedIn and I captured it. So it all starts with an awesome exposure. So if you can't get a direct path down the femur, you shouldn't be broaching, right? No matter how curved your stem inserter is or how curved your broach is, you really need to have a good shot of the femur. Nothing should take the place of a great exposure. And poor exposure is it's a big risk factor for a fracture because you're struggling. And if you're dealing with poor bone, I'd argue that you really need an even better exposure than you get normally. This is what it looks like when you should be exposed. I typically release the superior capsule. I typically release a portion of the conjoint tendon and then do a slight piriformis flip so I can see saddle point, and also I can see the externus tendon, which we preserve. You can obviously titrate these releases based on the femoral mobility. And if you have a bigger and stiffer hip, release more. If you have a high-risk femur with an osteoporotic canal, release more. It's that simple.